Hi, everyone. Good day and good evening, wherever in the world you're listening from. Firstly, I just want to give a little apology for the wonderful Sarah Hunstead, who would normally be joining me, but unfortunately is unwell. So she's in the background doing a little bit of the tech, so bear with us with things are a little bit wobbly, but unfortunately she's lost her voice. So we all wish her well, and she did extend her apologies to everyone. For those of you who don't know me, my name is Dr. Deb Levy. I am a holistic pediatrician, creator of Five to Thrive, and also mum to two young girls. I've worked with children for the past 15 years, and I have a clinical practice in Sydney's eastern suburbs. I'm actually currently on leave though, and I'm really throwing myself into my other passion, and that is spending time with parents and educating them, really giving you as parents the tools to not only help your children overcome illnesses, but to really help them thrive. So today's topic is a pretty big one. I am going to go through as much as I can, and I'd love to leave some time for questions that I will ask. So you're welcome to ask at any time, but I'll address them later on. Okay, so let's get going. Today we're talking about the unsettled baby. Okay, so I was just getting a message through from Sarah just to say that everything's working fine, so apologies for looking down. Okay, let's go. So what are we going to talk about today? Firstly, well, what's normal? I know when I became a mum for the first time, there were a lot of new norms that I had to learn, even as a pediatrician. So I want to share that with you. And then go through things like colic, the purple period, what is that? Reflux, the big one. And then if we have time, we can talk about UTIs, hair tourniquets and injuries, really just other reasons for babies to be crying and unsettled. I'd like to mention a free resource that I've created for you to go alongside these talks. And I've given the URL there. Alternatively, please head over to my Instagram page and you can find this free resource there. Okay, so crying really is a baby's only method of communication. They obviously can't talk to us, and so they'll let us know when they're uncomfortable, when they're hungry, when they're tired, wet, and I find that the first few weeks with a new baby is a time for getting to know each other. And by that, I mean parents and baby getting to know each other, the way they communicate, the routines, being out in the real world, baby learning how to feed. There's a lot of new experiences. So don't be too hard on yourself if initially you really can't work out what's going on. It is normal for babies to have some crying in the day. Having to try and differentiate normal from abnormal, there's this rough figure of around 2 hours of crying a day being normal. This can be, half an hour at one time, 15 minutes another time, but accumulatively. But the message of it when it's normal is that it's brief and they settle beautifully in between. It's really just that it doesn't seem to be an ongoing issue or where you can't settle them. And we'll go into that in a second. I think it's important always to know, to know when to worry. And what we talk about in healthcare are the red flags. And really what that is are a collection of symptoms or signs that make us more concerned that something more is going on. I'm not going to read through all of them, but I'd like you to just spend a moment or maybe screenshot this just to have a clear idea of what we as healthcare providers would be more concerned about. And I guess the big one is that really, if you cannot settle your baby, if no matter what you do, you cannot settle them, or if they've had any change in behavior, change in poops, change in nappies, change in feeding, change in their energy levels. Floppy is when newborns are literally just very lethargic and won't do anything. And then any signs of acute illness, a fever, rapid breathing, a rapid heart rate, a change in their color, or more long-term problems like poor weight gain. Okay, So now let's talk about colic. I've got a great graphic as well on Instagram. I'd love if you could go and follow me there, because I do share a lot of really helpful tips. So the first thing I want to say is colic is real. It's quite a controversial label, but it is real, but it's not a disease. And I think it's really important to be able to differentiate that, because it's very reassuring, really, if you know it's colic. Yes, it's incredibly painful when you're in it as the parent, but knowing that there's nothing physiologically wrong with your baby, I think provides a great sense of relief. That being said, it is a diagnosis of exclusion. So it's important for your baby to be examined thoroughly. They may need some tests done, such as a urine test or a sugar level, or depending on exactly what their presentation is. It's important for us to make sure that there isn't anything else going on. The other thing to note about colic is that it's thought to be part of normal development. Why babies do it, we haven't been able to work out, whether it's got to do with the maturation of their nervous system, of their gut. There's so many different hypotheses, but no one really knows. But the clinical picture is actually quite similar in terms of it starts at around about 2 weeks. Usually will get worse and then slowly goes away at around about 4 to 5 months. Typically, for the diagnosis of colic, it's more than 3 hours a day, more than 3 days a week, for more than 3 weeks. So that's a pretty long period of time. And it's typically also a chunk of the day. So it's not the entire day. It's usually just the afternoons or evenings when baby becomes fussy, really cranky. No matter what you do, you think, oh my goodness, are you hungry? Do you have wind? Like, what exactly is going on? They'll often go red in the face, pull their legs up, really just look uncomfortable and look like they're in pain. As I've already mentioned, there are no associated medical conditions, which is really reassuring. And then I've written also here limited treatment. So there's no medication that'll help. There are lots of over-the-counter solutions that are offered, but I've never found one that uniformly works. In terms of the evidence around probiotics, there is some evidence for Lactobacillus reuteri and for colic in exclusively breastfed babies. The evidence doesn't extend to formula fed, doesn't mean that it may not help, but the evidence just isn't as strong. The other point that I've made here about having a holistic approach, and this is the same for reflux, is that it's about looking at your baby as a whole in terms of the environment they're in as well. And the holistic approach that I always use, you may have heard me mention it before, are my 5 Ps. So I'm looking at, well, what's mom's nutrition if she's breastfeeding? Is there anything that's causing baby some discomfort, some more wind? Could it be, caffeine, peppermint tea, like all these funny things that can actually cause tummy symptoms in babies? Then you're going on to, a whole lot of other issues in terms of I could actually talk about this for hours, so I'll be as brief as I can. So, my next P would be play, which there I'm referring to is your baby overstimulated and that's why they're crying. Pause, are they overtired? So maybe they're just really exhausted, so that's why they're crying. So these are all the things we have to think of while we're establishing, is this colic, is this something else, and what can we do holistically to support Bub and mum and dad through this period of time. There's another term for colic, and it is rather interchangeable, and I think it's actually a really good one. It is coined by a US pediatrician who specializes in crying. Quite an interesting specialization, but he's formulated this term called purple period. The period isn't very clear there. So each letter stands for something, and describes pretty much what I've already been saying in terms of there's a peak, it's out of the blue, you can't soothe your baby, they look like they're in pain, and long-lasting meaning that it lasts for longer than 3 hours, and it's in the evening. But most importantly is that period at the end, in terms of it does end, they grow out of it. His theory is that it's very much a normal behavioral development, and the longer your baby goes on with this purple period, the more likely it is to be temperament related as well. That means personality. Okay, so the big one, reflux. So gastroesophageal reflux and gastroesophageal reflux disease. I just want to take you through the anatomy quickly, and then I want to explain the difference between the two, and we'll just go through a few things around that. So if you can see the picture there, if you're watching this, it's gastroesophageal reflux disease is when you have reflux of the contents of the stomach back up the food pipe or the esophagus. That happens in the majority of normal children, but it doesn't normally cause a problem. And that is the difference between GER or GERD. And you might see it also referred to as GOR, so G-O-R, or GORD, G-O-R-D, and that's just the spelling. One is the American and one is the more British way. For some reason, I've chosen the American way. I don't know why, sorry. So the gastroesophageal reflux is that small little bit that comes up. You know, this is why babies have those spit ups, you know, those little posits or spit ups that don't bother them. You just dab a little bit out of their mouth and that's it. Gastroesophageal reflux disease is when that reflux starts to cause problems. And those problems can either be pain, or it can be large vomiting as well. It may not always be vomiting though. Or what can happen is that reflux can actually come up and then they can breathe it in. So that can cause wheezing, chest infections, or it can actually cause recurrent ear infections. So that's the complications. So the way that I always describe it to parents is that there's this broad spectrum, this wide spectrum of reflux. The one hand, you've got these really harmless little spit-ups that'll go away as baby is becoming stronger with their tones, sitting up more and just growing. The other end of the extreme is the children who have the complications from reflux disease. And those are the children with the lung problems, the ear problems, and sometimes it can even cause damage, long-term damage to the esophagus. Thankfully, that's a minority of children. The majority of children that I see, obviously coming to a pediatrician, are in that space where they're having significant pain. They are showing me, and mom, but in terms of what I ask for, that this is causing them distress. And the classical signs are a little bit different to colic, but there can definitely be overlap. Usually, it's the pain. If you remember when I said with colic, it's usually one time of the day. With reflux, it can be any time of the day, i.e. when they feed. That makes sense, right? It can also often be worse when they're lying down just because of the gravity effect of the reflux getting worse. Any mum who's been pregnant with reflux will know that. The other issue is that, or the other difference is that I often find with colic babies, I'll pull their legs up to their chest. Whereas reflux babies, they have this very classic syndrome called Sandifer's syndrome, which basically means that they go stiff as a board and they turn their head to the side. It looks quite frightening, but this is just from the discomfort that they're feeling, as opposed to anything neurological going on, anything with their brain or nerves. The danger with reflux, other than the complications, is that the pain causes them to not want to feed. This can mean them pulling off. And if they're breastfeeding or bottle feeding, makes no difference. Refusing feeds, then they can have poor weight gain. And also long term, if this pain isn't properly, detected and managed, there's also a relation to developing then quite significant fussy eating, because babies start to learn to associate feeding with pain. So that's a negative association, which we really need to avoid. And as you can see, I've said the may or may not vomit. I've mentioned that already. That's the whole concept of silent reflux. Again, I know people feel that this is quite controversial. I mean, I don't think it is. I think either babies will vomit it up or maybe they'll just swallow it back down again. I think I've covered most things with reflux. Yes. Okay. In terms of how it presents. So these are all the things that give me a clue whether or not a child has reflux. Okay. So this is the holistic approach that I've mentioned earlier, my 5 Ps, my 5 to thrive. And really, I think it's a good way to approach reflux. I'm not going to go into it in huge detail, but I just want to point out a few things. One, I do believe it's important to gauge a pediatrician. The reason being that what I trying to put this the right way. What I think is always the best way to do things is with the least intervention. Okay, if that makes sense. So I prefer for children not to be on medication, for example, and I think that it's wonderful to be able to have a relationship with the doctor that you can go through a few steps to see where things are at, and hopefully with the initial steps you won't need to put your child on medication, and I'll talk about that in a second. Okay, so feeding techniques and milk. So just going down my 5 Ps again, plate, which is the nutrition part. Sometimes if a child has, I mean, I've had some children, for example, with tongue tie who've been diagnosed as reflux, and then when they've had their tongue tie corrected, their symptoms have improved, their feeding's improved. So, we do have to have a little bit of a broad mind about this. So I do think it's important to ensure that feeding is normal. The next point is around milk. There's a very close correlation between reflux and cow's milk protein intolerance. So I must be honest, the vast majority of babies who I see with possible reflux, I will do an elimination period of cow's milk dairy as well as soy, either mum's diet or switching baby's formula, depending on what baby's drinking. Development, I've already mentioned. So that's about keeping baby upright. So that's positioning. So development is about the period of time where a child starts to develop more tone in their body, and that definitely helps. So as much as they don't like it, tummy time is good. It just helps strengthen them, and those muscles help decrease the reflux. What I didn't mention, sorry, and I apologize, I'm going back now, is that the majority, around about 80% of children with reflux, will all resolve on their own by 12 months of age. So again, that's reassuring. The point they're making with positioning is what babies are lying on when they sleep, and also after feeding. So if your baby has reflux, they should be kept upright for 20 to 30 minutes after a feed. And then when they sleep, there's a wedge cushion there that I've included in the slide, because I want to reinforce that it is so important to make sure that we are complying with safety when it comes to our children's sleep, in the sleep environment, So nothing should go in the crib with them or the bassinet. This is a wedge cushion that goes underneath the mattress to help elevate their head. Self-care and soothing. I think that the soothing there I'm referring to is whether or not you want to consider a dummy or pacifier. There has, a lot of babies that I've seen have actually found relief by sucking, because you'll find reflux babies do want to suck all the time, because it seems to provide them with some kind of relief from the discomfort. And what you don't want to do is get into that cycle when you're breastfeeding all the time, because then they're getting more and more in their stomach, and then that can cause more reflux. The other thing I meant to mention is often having shorter, more frequent feeds can help. The microbiome, over the years, I've looked very hard looking for very clear evidence of this, and I haven't found any direct link between a specific strain and reflux, as we know with colic and the probiotic that I mentioned to you. But I certainly have found in my practice that babies who've had a difficult start often are more likely to have reflux. But again, there's no specific probiotic that I would recommend for babies with reflux. Medication. So this is the big one, and whether or not children require medication. Yes, I'm one of those really strange doctors that don't like children to be on medication. The reasoning twofold, really. One, I don't think medication is addressing the cause. And two, all medications have complications. The most common medication used for reflux, when I started my medical training, we used to use a lot of something called Zantac or ranitidine, and that is still used in very young babies. But what's much more commonly used now is something called a proton pump inhibitor, PPI, or I guess the trade names are Losec, Somac. I'm using all the Australian trade names just to give you an idea in case you've heard of these names before. And how those drugs all work is they decrease the acid secretion in your baby's stomach. And then the thought is that that then decreases the pain of the reflux because it's not acidic. It's the action of the drug isn't meant to impact on the vomiting, but anecdotally, I find often my patients will tell me that, oh my goodness, it has helped that. So that's a good side effect. The bad thing about PPIs is it does impact negatively on the microbiome, and I think one always needs to consider that as well. As you probably know, I am a strong believer in a healthy gut to nurture a healthy child. The query around when to consider medication, if you remember that spectrum that I spoke about, the really mild ones, obviously we're not talking about those children. The children who are in extreme pain, who are not gaining weight, or who have had any of those significant complications that I've mentioned, they are all more likely than not going to get medication sooner rather than later. Let me just unravel that a bit. They need medication. The other children who are in between, I often find that we can wait a little bit to see if we can use these other techniques that I've just touched on briefly. Obviously, I can't go into everything in such detail, and it's obviously a little bit different for every child. But I definitely think with those children, we've got a little bit of time to play with. But the other children who are suffering significant sequelae from it, we need to jump in, unfortunately. And the other important thing to note, is that all these antacids, they're licensed and tested for a 6 to 8 week treatment program, not ongoing endlessly. And I think that if after those 6 weeks one is unable to wean a child, then whether it's, we need to look further, whether it's a referral to a gastroenterologist or looking for what else it could be. But I do not believe in keeping children long-term on these medications. Okay, so I think I've kind of whipped through everything. I really hope that that's been helpful. I'm happy to answer some questions. There is my resource, and I'd love for you to follow me on Instagram. I'm going to be doing a live tomorrow as well as next week. Okay. That's great. Let me just tell Sarah to snap us out of this, and let me go on. Sarah's just pointed out to me very, very correctly that what I did not mention, so I apologize for that, was that wedge that I mentioned that needs to go under the mattress for safety should only be used during your daytime sleeps. In other words, during supervised sleeps, not in a nighttime sleep. So, you can see my little artwork from from my daughter. Okay, just I'm very happy to look for some questions now. Let me just see. Sarah. And I see that we've just linked to that now. Okay, cool. Great. So I hope that no questions means that I've already answered them all for you. Again, apologies for not being so clear, but thank you for posting that red nose information about safe sleep. Very, very important. And the other thing to note, again, also just about safe is reflux babies usually hate their car seats. Just a little aside there. But okay, one's popped up now that I'll just quickly answer, and then I think I'll say good night and goodbye. So we've got one from Methilia. I apologize if I've mispronounced your name. And if Sarah can pop that up, if she's listening, that would be wonderful. There you go. Thank you so much, Sarah. For children on the milder range with reflux, my newborn, when does it generally resolve? So I usually find that a lot of babies with very mild reflux will start to improve as they're sitting up more. And then often when they start solid. So usually by 6 months, and then if not by 6 months, by 12 months. So I hope that answers your question. Okay, great. Thanks so much, everyone, for your time. I really hope that that's been useful for you. Please come follow me on Instagram and feel free to DM me there with any other questions. Alternatively, I'm happy to answer questions. See you next week. Oh, yes, I should tell you about next week. Next week, we're talking about the weird and wonderful things of newborns. From top to toe, I'm kind of just going to go run through everything that I think could cause you some stress or distress, and we're just going to talk through them all. Okay, great. Thanks. Have a great day, everyone. Bye.